So we just have about 10 minutes for questions for our faculty. And as before, I'm just going to go from between our faculty in the hope that we can answer at least most of them. Uh, the first question is, Jerry, how does voclosporin compare to other cheaper CNIs like tacrolimus? Are these patients achieving remission because of hemodynamic effects or immunologic effects, do you think?
I think their immunologic effects and how it compares, it's more expensive. This is a big question because you don't have comparative trials with a similar drug in terms of this. And now the most amazing thing is that they got by with very little prednisone, which in both the placebo group and the group that got the Voclos, which says we can use less steroids. But I would love to see a controlled trial, saying that one method is better than the other. And they adjust the dose of the voclosporin based on the creatinine. I'd love to see a study that we did that with TAC, based the TAC on the creatinine, probably come out with very good results. So
Yeah. Larry, what would you do? What would you suggest for a patient with PLA2 membranous who receives 2 doses of rituximab, responds, and then relapses? You switch him to a calcineurin for the relapse, and he responds, but then as soon as it's stopped, the PLA2 comes back. Would you keep the patient on TAC indefinitely, or what would be your preferred therapy?
Yeah, I assume that responding to the first 2 doses of rituximab meant getting to a completely negative anti-PLA2R. And then I think it's reasonable I might have, depending on the clinical circumstances, I might have gone back to rituximab the second time, assuming that maybe you just need to do it longer. But others have used TAC or cyclosporin first to lower the proteinuria and sort of get them out of a nephrotic range, and then give the anti-CD20 so it hangs around longer. It's not lost, in nephrotic levels of proteinuria. But I would continue to follow anti-PLA2R, and if it takes further dosing of rituximab, or the thought is maybe with the first generation anti-CD20s, they're not quite getting all the tissue penetration that something like a type 2 obinutuzumab would get. So maybe try to get that, but I think it's reasonable to do TAC at first, but I'd probably give rituximab and not continue tacrolimus indefinitely.
Okay. Would you use obinutuzumab in those circumstances, especially for?
Well, it depends what I think the failure is. I mean, if I checked CD19 B cell counts and they weren't completely suppressed after rituximab, that maybe they have antibodies interfering, and you might want to try a different molecule. So I think it depends on a lot of things. But yeah, I've certainly treated rituximab-resistant patients with OB with better effect.
Mm-hmm. And for a patient with primary, this was a separate question. For a patient with primary membranous and severe proteinuria, do you use corticosteroids to treat them quickly before the Ritux kicks in, or do you just give rituximab thinking it'll happen quickly enough?
I mean, I use certainly all the conservative therapies and RAS inhibition and SGLT2, and I think that might be a situation where you want to do a CNI up front, just sort of keep it at a moderate dose so you're not inducing nephrotoxicity, but you're getting the proteinuria down. I think there is some effect on the anti-PLA2R because we see in the studies like Majesty, you can see the anti-PLA2R coming down a little bit when they're on tacrolimus, and then it goes back up. So I think there's also an immune suppressive effect that's proteinuria lowering, but I don't use prednisone in that situation.
Jerry, back to you. Would you consider triple therapy for class 2 lupus on biopsy who has a declining GFR or protein above 0.5 grams per 24 hours and highly elevated immunologic markers? Would you
If it-
ever treat class 2?
I would look at the biopsy carefully in terms of now if it says class 2 and there are only 5 glomeruli, and we may be missing a whole bunch of other ones that are much worse in terms of that. But if it's progressing and it's true class 2, that there's something else going on here that we're missing. And if it's an inadequate biopsy or not a very generous biopsy, I would just repeat it. That's the bottom line in that, because again, if it's active, you don't want to miss it, and if it's all scarring, then you want to end up, treating with non-specific therapy.
Yeah. And for initiation therapy with newer agents, how do you decide when to switch to maintenance? Is it disease activity? What's the typical duration of therapies for initiation?
Yeah, well, the typical has been 6 months, to use 6 months for induction therapy and then switch over, and that was, based on a number of different trials in terms of like in the ARMS trial, for instance, you got 6 months of mycophenolate and then the dose was lowered down. And it's the same thing with a number of other studies. So I think that's, pretty reasonable in terms of, giving them for
So
OB,
for newer
you know,
agents,
for a newer agent like newest being obinutuzumab, so they really got doses at 1, 6, and 12 months. And then you could think about going on to some kind of maintenance or spacing out the obinutuzumab in terms of that.
okay. And have you altered? Do you give antibiotic therapies with the newer agents? Are you more quicker to cover with antibiotics?
I have not. I have not used prophylactic antibiotics in terms of this. The only, disease I routinely try to do that in is ANCA-vasculitis. But that's probably because a lot of them have upper respiratory infections and everything. But no, I have not. I mean, we do try to screen for infections beforehand, and certainly before using rituximab or obinutuzumab, we do a quantiferon, gold for TB and chest X-ray, and then the other thing is you look for, antibody for hepatitis C, either antigen or a core antibody. I mean, those would be. I'm sorry, hepatitis B. You want to do those, yes.
And Dr. Beck, if you had a patient with a persistent low positive PLA2R titer, approximately 1 to 32, who has chronic hyperechoic kidneys and a creatinine that's increasing to 2.5, would a low titer justify additional B cell depletion therapy, or would you consider that burnt out CKD?
Yeah, I think it depends on how many nephrons you have to save. There was a case series years ago that looked at use of rituximab in that situation. I don't know if they were as low titer as 1 to 32, but they did put patients into remission. They did stave off end-stage kidney disease. So I think I would try, especially if they're seropositive and there's evidence of activity, low serum albumin. If it's sort of non-consequential and their albumin's near normal and they have 2 grams of protein, I might just continue supportive. But I think if there's ongoing damage to the glomerulus and nephrotic range proteinuria, I would try to treat that.
Yeah, that's and Jerry, for class 4 lupus, how do you decide? What's your decision point in using belimumab versus a CNI with triple therapy?
I use a lot of belimumab because it's been around a long time. It can be given sub-Q and IV. It's got great safety data in terms of long term. I mean, it's approved for kids over the age, I think, of 5 or 8, something like that. But if the FDA approves something in kids, it's usually a pretty safe drug. That on the other hand, if somebody had very heavy proteinuria with it, that's where that question comes up about whether belimumab is good thing to go to first, or use something like voclosporin, which is, being a calcineurin inhibitor, is usually pretty good for heavier proteinuria.
Okay. There were a couple of questions for Dr. Maloney that I think I can handle a couple of them, but then we're out of time and we could get back to you on those. One of them, the diagnoses, what diagnosis contraindicates the use of ESAs? And as Brona had mentioned, certainly malignancy, it's a relative contraindication. It requires a discussion, and it is dependent to some degree on whether it's a curable cancer or not. It's which is, I believe, KDIGO's most recent take on it. The cardiovascular complications, a recent event, is a good relative contraindication to starting an ESA. Long-term cardiovascular describes almost all of our patients, and they still require ESAs. There was another question regarding evidence supporting specific oral iron preparations. There's an excellent review in AJKD. There are three relatively newer agents that all have better GI profiles. The problem is that they're exorbitantly expensive for oral medications compared to the old stuff. One of them is available without a prescription, and that's probably your go-to agent. It's the cheapest. It's soprosomial iron. But there are a number of agents coming down the pike, and they all seem to be better liked by patients. And then there were a couple here. Yeah, I think that's probably the bulk of the questions. If there are any that we missed, again, Brona had to leave early today. We can certainly respond by email with a more complete answer.
If there are any you can't answer, Larry will answer them.
Well, yeah, that is well, Larry, in that case.
No.
Yeah, one of the patients on Jardiance is having higher hemoglobin levels. Has it altered the use of ESAs? Well, hydrate that patient, but I'll see if Brona has come across any more recent data on the use of PHIs or erythropoietin in those patients. But I would like to thank certainly all of our faculty for delivering excellent, edifying lectures. It's truly appreciated by us.
Thank you for having us.
Yeah, thank you.
And with that, to all a good night.